Can y'all hear me
How are you
okay?
doing?
Good, how are y'all? Can you hear me okay?
Yes. Yes, we can.
Awesome.
Well, let's hold on. Let's say, guys, can you hear her okay? I can hear her. Can anyone else? Yes. All right.
Awesome.
How
Can I
are
have
you
like a
doing tonight?
little... I'm doing great. How are you?
Doing pretty good. Doing pretty good. It's going to be like when I say that we have so many things going on that we stay busy right now, but we are here, we are ready, and I know that there are some people who are in the chat who are excited to hear what you have to say.
I am so
So
excited to be here. Thanks for having me.
I really appreciate that you took time out of your schedule to be here for us because, I mean, honestly, and I want to say this for our community, she's not getting anything out of this, guys. She's doing this purely for you, okay? Like, you guys are the reason why she's here.
I
We are
am very
just like
passionate about this.
our platform here is just facilitating her being able to speak to you guys. So if you have questions, start putting the questions in now. Our moderators are going to get them and send them to me if I don't see them, okay? Because one thing is with you being a guest, we won't be able to pin the comment. So I'm gonna be looking at my phone so I don't miss any of the comments. I'm not being rude, I promise.
Of course. No worries at all. I know I'm also like technologically challenged, so people might need to help me out.
Not a problem.
So I also know that you guys said it takes a while for like everybody to join. So I wasn't sure if now is a good time to give an overview of like the framework I typically use and like an update on the research.
Honestly, it's gonna probably be smart for like every about 20 minutes for you to go over it again.
Okay.
It's not gonna be repetitive, but because TikTok is the 3-second swipers,
It's true.
that way we can get the more people to see and hear and all that. So okay.
Absolutely. Well, I can also tell y'all a bit more about myself, but I am a pediatric psychologist, which means I am a licensed clinical psychologist and I specialize in clinical child and adolescent psychology. But when I was in graduate school, I started working for a practicum training site, actually with a person who I think is going to be watching this live. So hi, Dr. Danita. And so she trained me. Look at me now. And I just developed a love for kind of somatic disorders, but also functional disorders, and my clinical residency and then my clinical fellowship all kind of focused a bit more on like functional symptoms in particular. And so, again, I am trained in working with children and families, so I'm less familiar with research on adults and a little bit less familiar with like adult treatment. Nowadays, like I do think the treatment will be similar, but I cannot speak to adult treatment as confidently. And then obviously disclaimer, I will be sharing general information that I've learned throughout my training and from the literature and the research. This is just the approach I use. If that is not something that you think would work for you, that's okay. So again,
well, one thing that I like to say is if you hear something that we talk about that you're interested in, talk to your medical professionals, talk to your medical team, because trying something that works for me without talking to your doctors first is never advised.
Exactly.
We talk about what happens and works for me, but that doesn't mean that it's going to work for someone else. And so one thing that like you were saying, we always say that, talk to your medical professionals. You can take our advice that we're giving as my lived experience and your knowledge, but before you do anything, before you act, make sure you talk to your own medical team.
Definitely. And absolutely. And also, again, I'm not a medical professional. Like I work in healthcare, I work in a hospital setting. I'm affiliated with a hospital. That's where I do all my work. But I'm not a MD or a DO, so I'm not medically trained. Again, it's a clinical PhD. So again, talk to your neurologist, talk to your psychologist, your physical therapist, whoever you're working with. Hi, JD.
Hi, how are you?
So I have a question that's already come into the comments, and I want to go ahead and ask you really quick. Okay?
Sure.
So Mrs. Tate says FMD and DNA. Mrs. Tate has FMD. Her daughter has grand mal and similar symptoms that started at 15. Is this hereditary?
That's a great question, and that will be a nice segue into like a general overview of the way we view FND based on like the newer literature coming out. So, show of hands, what have people been told so far? What causes FND? Like, what is the?
I can tell you that one. It's all in your head.
It's all in your head, and so what caused it? I've heard a lot of it's trauma. Oh, it looks like the creator paused.
No, we're here.
Okay. So yeah, it's all in your head, right? Which is, I think, kind of funny in that, like, to be fair, everything we do is in our head. Like, that's where humans think of anything. Okay, see, head trauma or stress, trauma. That's the most common one we get and we hear. And so actually, based on the newer literature, that is not necessarily linked directly to FND development, right? There are plenty of people who have trauma experiences or adverse experiences who do not develop FND. And the reverse is true as well. So we do have people diagnosed with FND who do not have experiences of trauma. I'm also seeing a lot of like stress, right? It's a lot of anxiety, it's a lot of stress. And obviously anxiety and stress make everything worse, right? Anything that's related to our regulation, it will probably maybe increase your symptoms, but not necessarily. And so a lot of the new research, the only thing that we're consistently finding that is like across many of our FND patients is something called like somatization or like interoception. So basically being very in tune with physical sensations that you're having in your body and then how your brain interprets them. So slay a psychologist today. I love that. So all that to say, the newer framework is kind of multifold. We take a biopsychosocial model, and I swear, mistake, I will get to your answer. I'm just going about it in a slightly roundabout way because I do think the context is going to be relevant. So when we think about FND, we often think biopsychosocial. So the biology part, I'm going to talk about more like predisposing factors. So a lot of our kiddos have epilepsy too, right? A lot of our kids have comorbid FND and epilepsy, or they might have migraines, or they might have some other neurological or even like other just like physical conditions. So POTS is another common one we see comorbidity with, right? And so that might be a predisposing factor. And then we talk about—
My neurologist actually wants me to be checked for Ehlers-Danlos and also POTS, and there was one other thing. Oh, I also they want me to do genetic testing too. But yeah, so because of just things that they saw in the doctor's office, now they're like, oh wait, you already have this. Let's now check all of these too.
Mm-hmm. And that might not be a bad idea because part of what we now think or know can kind of contribute to FND is basically our body misinterpreting signals, right? So a lot of us talk about the mind-body connection, but what does that actually mean, right? And so when it comes to talking about FND, it's almost like, have you guys ever had food poisoning? Like, let's say I gave y'all shrimp and then you vomited. Mm-hmm. What if I gave you shrimp the next day? Would y'all want to eat it?
Yep.
I just ate shrimp today, so I'm gonna use something else.
Yeah. So if I give you shrimp, you vomited. JD, I promise I did not give you bad shrimp. But if I were to give you bad shrimp, I would offer it to you again. And even if maybe it wasn't the shrimp that triggered vomiting today, if I offered that same shrimp to you tomorrow, you might get nauseous, right? You might not feel well. And that's because your body is kind of connecting those two experiences, right? Like it's connecting the experience of eating the shrimp to vomiting, to that physical expression. And so sometimes our brain likes to take shortcuts. And so sometimes that's helpful, but sometimes it's not. And it might make an inaccurate prediction. So it's almost like a conditioned response is how we think about FND sometimes, rather than trauma or stress. So it's kind of like your body misinterprets the signal that the brain sends and vice versa. So when it comes to genetic links, there might not be a genetic link specifically to developing FND. See, I'm finally made the full circle to the question. There might not be specifically a, like, as of now, I don't think there's a known genetic variant or anything like that. I do think there are some functional differences in the brain, right? Like from functional MRIs, we know there are different activation areas that are more prevalent or less prevalent in individuals with FND versus without. We also know that sometimes our body can misinterpret signals, even if they just see somebody else have an episode or a seizure or a medical event. So if your daughter, for example, has seen you experience episodes, that might be a predisposing factor for her to develop it. So it might
ask you a question about that because I've actually heard someone actually messaged me about the fact that her child's doctor said that she needed to get off TikTok because seeing people have seizures is the only reason why she had seizures.
Yeah, that's amazing, right?
It might not be the only reason, but it can definitely be a contributing factor because, again, our brain likes to make quick predictions. And like another example I often use, kind of a metaphor, is if you're driving home and you're like parked and then you're like, oh, did I drive by the street? And you know in your brain that of course you drove by the street. That's how you get home, but you might not actively encode it, might not actively remember it, right? And so that is another example of our brain making a shortcut. And so, yeah, seeing somebody with like functional tics, for example, or functional movement disorders, that can be a contribution. And I see you mentioned, did you watch the trauma? I went through and experienced some of the trauma too. And so kind of going back to trauma, like while a trauma might not cause FND, if we're talking about, sorry, I'm like, I can't focus on talking and also like looking at the incoming comments. So I need to not look.
Honestly, don't worry about the comments because my mods are like, I'm screenshotting the comments and stuff, and my mods are writing stuff down. So you just keep talking, okay?
And some of the comments are from before you came on.
Okay, gotcha. Honestly, I forgot what I was saying, but all that to say is that there are so many different things that can go into it. And so with trauma, like we know that trauma can have an impact on the body, right? Especially on the nervous system. So if our nervous system is more activated, so if we're in fight or flight, we are more likely to then develop FND potentially. Again, not everyone with trauma will develop it, right?
Right, yeah.
So that's kind of the important part to distinguish. And now we don't dig for trauma. Like you can be diagnosed with FND without any other mental health condition.
That's good.
All right, I'm sorry. So there was a question I wanted to ask you because I don't know how to say the words, and so I'm gonna just do my best. Okay. So can a child with FND also have, and it's SANFILLIPO syndrome?
I will be honest, I like off the top of my head, I'm not sure what that syndrome is. I could look it up, but yes, a lot of our kids have general comorbidities. Like a lot of the people I work with FND will have some other comorbid medical diagnosis or sometimes psychiatric diagnosis, whether that's anxiety, whether that's trauma, whether that's like POTS or something like that.
Okay, so there's been a couple of different people who've had this question about migraines.
Mm-hmm.
Are there, from what I'm understanding, they kind of want to know if the migraines could be the cause of, could that be the triggering cause of?
Right.
That was the only thing that they were diagnosed with before.
Mm-hmm. Yeah. And again, like it could be a contributing factor. So it could be a precipitating factor, right? Where you might have migraines and that causes weird physical sensations, right? Like migraines cause all sort of physical sensations, nausea, vomiting, like obviously the headache part, like aura, all of that. And all of those could also be FND symptoms, right? So your body might misinterpret a cue. So like, let's say you normally have migraines and then you know you're going to get a migraine because you have an aura or you get a nauseous feeling. And so let's say another day you're noticing you're nauseous or you're noticing you have the aura and your brain goes, oh, like I know what this is. This is a migraine, and it's going to trigger all the physical symptoms, even if maybe it isn't a migraine going on. Maybe at that point it becomes more functional. But basically it's your brain being like, oh, I know these symptoms and I know what I need to do when I have these symptoms.
So a couple questions. Okay, so the syndrome that they were talking about is childhood Alzheimer's is what it is.
Okay. I'm sure there can be comorbidities.
Okay. And the next question is, how young can this diagnosis be made?
I saw some recent literature that was saying it can be as young as like 4. I'll be honest, that is, I've never seen that in my career. I would say most often it is like teenage age is when it starts being diagnosed. So I would say it used to be like 13-ish was that like earlier onset, but now I can see a lot of patients who are like 8, 9 years old who might develop some of these functional symptoms. And we don't quite know why people are getting it younger. I don't know if we're better at capturing it. I don't know if people are more aware of the diagnosis.
Yeah.
It could be a bunch of different things.
I know that Justin has had parents who reach out to him, and their children have been in the 6-7 year range.
I'm going to tell the truth.
I
I will never forget the dad that reached out to me at 3 a.m. and I spoke with him, and his child was 4 years old. So that's about the age that I see a lot. And like she's right, parents around 6, 7 years old.
Yeah, I just know you because you talked to me about that.
Yeah, there's been a few parents that quite a few actually. The age range was 3, 4 years old, and they're seeing the same symptoms that Rachel has. So why is it that, and I'm asking this, but I've heard it before, but why is it that you don't diagnose, they haven't diagnosed children that young yet?
I mean, off the top of my head, I'm not sure. I can't answer like why. I'm wondering if part of it could be, at 4, it's really hard to express what you're feeling and what's going on, right? So they're going off of like examination. And for example, like a lot of mental health concerns present very differently in younger kids. So like I specialize 6 and up. I do some like newborns and babies with like cleft lip and palate, but most of my kids are 6 and up because under 6 is a very different, like there's so much that happens, and a lot of mental health concerns, including like anxiety, depression, just presents differently. So it could be that we just don't know how to diagnose so early. Could be that the presentation is very different.
So many factors. Yeah, right.
Okay, so someone's asking if you know what the difference between FND and PANS or PANDAS.
PNDS?
PA.
Yeah. So FND is like a psychiatric diagnosis that presents like a neuropsychiatric diagnosis, right? So it's diagnosed by neurologists, but then a lot of psychologists, neurologists, and physical therapists treat it in a multidisciplinary setting. And we can talk about treatment, like newer treatment that's been coming out. PANS and PANDAS can be considered a controversial diagnosis amongst the scientific community. Again, I'm not a medical provider, but there can be some like cognitive presentations. There can be some OCD presentations when a patient suspects they have PANS or PANDAS. But those are kind of like PANDAS we consider more of like a medical diagnosis, like a medical explanation for a diagnosis. Like some people think it's caused by mold or allergies or things like that. But yeah, those are very like different. Like FND, and I also saw a question, like maybe an overview is helpful. So FND, functional neurological disorder, basically it can present a variety of different ways, right? A really common one is the seizure-like activity, right? That's the one that a lot of us see and treat. There's also movement disorders, things like abnormal gait. There's also paralysis presentation. There's also more cognitive symptoms. So I saw a question earlier that there were asking about speech differences, like if a child develops like functional speech concerns, or if a child develops, or I guess an adult, I forget, I'm not just with pediatrics. There are cognitive like memory loss, confusion. There are cognitive FND symptoms. And the treatment approach is going to be similar. So I'm guessing a lot of people have heard things like cognitive behavioral therapy, right? So that's a common one that used to be used. And it's basically where you target from the top down, right? You target your cognitions, you target like your interpretation of the signals. And for some people that is really helpful, right? That can work really well. A lot of the newer treatments that I'm trained in and that I find really helpful for a lot of my families, a lot of my patients, is something called REACT, which is retraining and control therapy. So it's a combination of bottom-up approaches where we almost do, the best like example is almost like tic habit reversal. So we work with the actual FND symptoms and we create what we call an opposing response for every single symptom. And I can give some examples. And then of course there's more of a cognitive component where we do the like challenging thoughts and like coming up with ways to feel safe or kind of how to feel a bit more in control. Because again, the biggest predictors of kind of recovery is one, buy-in and understanding of the diagnosis. and feeling a sense of agency over it over time. So, for example, if I were to work with, I don't know, Rachel, do you want me to use you as an example? If I were to work with you, let's say, how can you tell you might have an episode?
You're asking me how I can tell? I sometimes I can't tell. That's part of the problem with mine.
Mhm.
Most often, I can't tell before it happens.
But I can tell before they're coming.
Now he can tell before I can.
So JD, how can you tell?
So one is slurred speech.
Mm-hmm.
It's the cognitive decline.
Mm-hmm.
I can see
My movement
her
changes
movement.
when things
Sometimes the time of day. If the weather is changing, I know one's getting ready to come on. I can feel a temperature shift or weight in the what is it? We have humidity here in Virginia, so we can feel like the weight of it happening. And I'm like, well, if I'm feeling that, she's about to go into it. And then there's also observing her daily. If something is off about what is our interaction or our interaction with others, I can feel it coming. But there's sometimes where you'll see me videos of us in the out and about. So it's not just the stores, but just out everywhere. And I will feel something, and I can't explain it. It's intuition. And I'll know she's about to have one, and I'll try to get there before she gets to, hits the floor.
Like I actually had one a couple days ago where I was in the pantry and he went to the refrigerator, turned and walked into the living room, and I went from standing up inside the pantry to flat on my back.
Mm-hmm.
It literally was, there was no warning. I couldn't, and I guess the problem for me was like, once I got into it, like I was doing everything I could to hold my body upright because I knew I was going down, but I was already fully locked in and I couldn't say anything. I couldn't grab anything. Like everything in me was like, Rachel, just grab the door frame. It's right there. Your arm is touching it. You can grab it, but physically, I can't do anything.
Yeah, it's the loss of motor skills and it's the loss of verbal skills at that point.
And
that's
it's
when you start to
really
notice
frustrating because my brain is functioning.
Mm-hmm.
I'm still thinking, and like sometimes, like I've had doctors say that I need to go through the seizure episodes and not be brought out. And so Justin will leave me in them.
Yeah.
And he will have conversations with me so that I don't feel alone. And I'm responding. He just can't hear me.
Mm-hmm.
Yeah, her lips are not moving. So yeah, to answer your question, yes. There are certain things that we can see.
Oh yeah. So there is one thing I do, and I didn't even think about it. Pickle mentioned it. I'll say I'm fine.
I'm fine. Yeah, she'll say it repeatedly.
But it's not me saying it, honestly. Like it's not like I'm not trying to say it. It's like he'll say, Rachel, you doing okay? I'm fine.
It's involuntary.
Mm-hmm. And so that's super helpful. So, and again, I'm not your psychologist, but if this was like a role play, so Rachel, are you still kind of aware when you say I'm fine, or would you say you're kind of already out of it?
Both.
It depends on the
I
day.
mean, honestly, I know that answer is not helpful, but it's 100% the truth at the same time. There are some days when I'll say I'm fine, and then the next thing I'm like, no, I'm actually okay. Everything's fine. I'm okay.
Mm-hmm.
I realize that I have to like rephrase how I say things because when someone asks if you're doing okay, a lot of times people will be like, yeah, I'm fine. Because that's an automatic response, especially in society, you know?
Right.
And so like most of the time people are not going to say, no, I'm doing great, thanks, on a regular conversation with family and friends. You know what I'm saying?
And we'll sit there. For me, I literally talked about that in my book. So I like with men, we'll say I'm fine, and that's code for you. I'm not really fine. I just don't want to share my emotions right now. Well, with her, if she says I'm fine, I can tell it's a trigger. So I'll say, or not a trigger, but a tick. And so I'll go, okay, so let's sit here and talk about this. Are you actually fine? Or are you really getting ready to go through something? And it's giving her an opportunity.
If I can't respond, actually respond to him, then he knows that I'm already in it.
Mm-hmm.
Does that make sense?
Mm-hmm.
Okay. Sorry.
That makes sense.
Yeah, this is super helpful. So, and the reason I was asking is that often people can't tell until like it's happening, but a lot of people like around them might be able to tell, or we would want to be like preventative. So like, let's say if you're saying I'm fine, you're like still mostly kind of alert, that would be a time when we would implement what we call like our plan, and we're going to create a plan. But it is helpful to begin to notice patterns or triggers. And for a lot of people, there might not be any, in which case we'll kind of let the episode happen and we'll talk about like what to do in that case. But over time, people begin to get, especially if you've been having it for a while, you get really good at like telling it's about to happen. I saw like Pickle comment, like I can tell, and then Jade can tell. And so when we, for example, feel a sensation that it's about to happen, or you feel the I'm fine coming on, or you feel the stuttering coming on, we would start implementing opposing responses for every single one of your symptoms. So let's say if the episodes are they just full body shaking, or does it include like the stuttering consistently?
So that was a good question. So no, Rachel is one of the very few that I've met that doesn't have a consistent basis. Like in the very beginning,
It was very consistent.
it was very consistent. But as time progressed, where should have been getting better with all the treatment that she was getting, all the therapies and physical, speech therapy,
speech therapy, mental
yes,
therapy,
all
talk
of that
therapy.
should have been getting better. As those went on, it started to gradually get worse. But that's when we started to implement little tasks that we would do when a certain one would happen, or when we thought a certain one would happen based on the time of day or what she has been going through or what we can see happening before she goes into it.
One thing I want to preface with you is I'm sure that you watch some of my videos, most likely. And so we use a spray bottle for me, and we also use the different thumps. None of these came just because they want to do things to me.
No.
The spray was that suggested? It was the
No.
water was.
I was sitting there washing dishes. I was sitting there washing
after
dishes.
we talked to my neurologist,
She said, "Well, yeah, that
that
sounds amazing." Because I showed her the video because we have cameras and we had them in our old house. And I was washing the dishes, and she was about to fall behind me, and I grabbed her and I laid her down, and I kept washing the dish, and I was trying to think, how can I get her out of this one if it goes too long? But I was told to let her stay in it for at least 5 minutes. And so I let her stay in for 5 minutes. I grabbed a cup of cold water and I splashed it on, and I realized
it works.
it works.
Mm-hmm.
But the
rest of them are research.
Well, the thumps you saw first.
I saw it in the hospital.
The hospital used that on me.
Mm-hmm.
And when I was in the hospital, that was their response to when my brain shut down and I stopped breathing for over 3 minutes.
And to calm her down with the seizures.
These are the brachial plexus compression. And again, it does almost like a full full relaxation of, especially when I get too tense and I have no control over that, which is quite often.
Yeah.
Now, again, I'm going to say this for everyone who's watching.
Yeah,
I am not a medical professional. He is not your medical professional.
She is not your medical professional.
What we are talking about are things that we have worked with my medical team that help for me. Because one of the reasons why my neurologist originally was like, we have to find something that's going to help her not stay in the seizures or the episodes, whatever they are called where you are. I was doing things to try and hurt myself to bring myself out of them.
But she didn't know she was
I didn't realize I was doing it until I would have blood and things like that.
She had scars all over her body because involuntarily she would dig into her arm trying to get herself out of it.
Mm-hmm.
And into her chest and things like that. And I would notice these things. But then I realized it clicked to me that, she needs pressure. She needs pressure. But we need a better way of handling this.
So the things that work for me because of talking with my doctors and finding things that'll work that were not harmful.
Mm-hmm. And that's a great point. Kind of finding
a balance.
Ways to not be bloody after an episode, I think would be ideal.
Yes.
Yeah.
I think that'd be great.
She's already had an episode of seizure. We would like you to, get up and be fine after that, as far as not bleeding all over the floor. So it was very tense in the very beginning.
Yeah, and what you're describing is like what they call in general like noxious stimuli, right? So some teams, especially like more old school neurologists, I've noticed will recommend that family members or like caregivers in the case of kids do like the way you can describe, like either like a sternal rub or like a pinch. And often it works, sometimes it doesn't, right? And so in that case is where we kind of want to build that agency within the person themselves. So, because the tricky part would be like, Rachel might not be able to come out of them on her own because consistently it's always been somebody else bringing her out of them, right? Again,
I've never been able to bring myself out of them on my own. And one of the things that like my doctors have taught, well, my neurologist talked to me about was the fact that my body reacts to pain differently. And because I stay at a high level of pain because of what happened to me back in 2013, my brain struggles to understand pain that is happening currently and the residual that I'm in pain at all times.
right.
And so because of that, I've had where like, well, talk therapy and things like that don't work well for me because I've had multiple people tell me that I'm coping so well that there's nothing they can do for me.
Right.
And so with that, it's kind of almost a lot of treatments that will work for other people, my brain and body reject.
And that's kind of why we would want to, we personalize every treatment, right? So there is not necessarily one size fits all. And that's why I like the treatment that's called React. And I think I've emailed you guys the link to the website, and they offer, it's a research project. So, but they have a lot of evidence behind it. And there's so many publications already out about.
I wanted to double check with you. The stuff that you sent to us, is that things that it's okay for us to give to the people in the community who might ask about it?
Maybe I would recommend the links. I mean, you can share the articles too. I think sometimes there's so much like lingo in it that's not very helpful. But I would say the websites that I sent can be helpful. And so, yeah, I see a question about talk therapy. So yeah, often talking about the episodes is not enough. And that's a lot of times why people think therapy doesn't work for FND, because talking about the symptoms might not be enough. And so that's why I really like to use the React approach, which is basically creating an opposing response for every single symptom. And I can kind of talk through what that looks like in general and examples of how to personalize it and tailor it for every single person. But that was a great question. So React is, again, retraining and control therapy. It's developed at University of Alabama, Birmingham by Dr. Fobian, who also trained at the same hospital I work at before. And she was also trained by the same person I was trained by. So clearly, we were all kind of on the same page. But basically, like you said, we often have different types of presentations, and you kind of described like what I would call like the whack-a-mole presentation, right? Like you get one symptom under control, another one pops up. Yes. And that's because, and you know, that could actually be sometimes a good sign. So we'll talk about extinction bursts as well, because that can be super common. Ooh, I'm going to UAB in August. I think you're going to, if you're meeting with Dr. Fobian or her team, I do think you'll have a really positive experience. She's fantastic. So let's say I'm going to use an example of like a teenager that's coming in, and right before they have an episode, they can't really tell, but maybe like the parent can. And we'll begin to kind of monitor like what are some triggers, things like that. And before an episode happens would be ideal to catch it, but even if we don't, that's okay. We will have another part of the plan that is in charge of like what to do if the episode does happen. So let's say it starts with and there's also like what we know about FND, is continuous symptoms, right? So it's, for example, weakness or paralysis or like gait changes. Those can be continuous symptoms where they're always there. And then there's episodic. So like this usual like activity is usually episodic. Right. And we would treat those kind of similarly, but kind of differently. Again, that's why the personalization is so important.
Yeah, we definitely say you can't put anybody in a box in the medical field.
Right. Random, I hope that you feel better. We love you, and I'm so glad that you were here. Sorry, one of the people in the community, she's having some episodes tonight, so she's heading on to bed before it gets worse. So
no worries. Oh yeah. But okay, so talking about the opposing responses, there are some common ones that we can recommend, and then we build on what based on what the person tells us. So the goal is, again, if we're thinking of FND as an automatic response that is not very helpful, right? It's basically your body misinterpreting the signal and doing a movement that's not purposeful. So what we want to do is either right before an episode starts or like once we're coming out of one, I'm going to talk as if we are about to have one and we're trying to prevent it. So we would start doing controlled, large, purposeful movements. So for example, if I am a person who has full body seizures, not only would I start before, like when I start to feel like weird or feel an episode coming on, I would start doing large controlled movements like think Pilates princess where it's controlled, right? It's very muscle tone. It's very much you are choosing to do it. And it can be like big like a star, it can be arm windmills. At the same time, I would also do leg movements if I have full body seizures, right? I'd want to do the arms and the legs. So like bicycle kicks is a common one. I also forgot to say in the beginning, if you even suspect you might have an episode, sit down, right? So let's say you're standing wherever you are, we'd want you to sit down as soon as you have even the minor suspicion of an episode about to happen. So you would sit down, and then from the sit-in position, you would do the arm movements, the leg movements. And at the same time, for a lot of people who do have the non-epileptic episodes, they have like a loss of consciousness, right? So what we want to do is start moving your neck around at the same time and naming either out loud or in your head what you can see. So kind of like a visual grounding. So basically you are trying to override your brain's response. And most likely the first few times might not work very well, right? But the goal is that you're starting to notice that you're about to have an episode. You're starting to develop these controlled movements in advance and try to prevent it from happening. Sometimes that can be enough, like just even knowing that can be enough for like a lot of our patients to improve. Obviously, it takes time for other people, right? Especially if you've had it for a long time. And we might actually experience an exacerbation. So kind of like with kids and temper tantrums, when we start to address that, we would expect temper tantrums to get worse.
Right.
And it is the exact same way that we expect for FND. And that means it's working. So kind of Rachel, when you mentioned earlier that, sometimes new symptoms pop up, it might be because you were getting better and better at controlling some of the other symptoms and your body is like, well, gotta come up with something else now, right? Like your body will push back against it basically. And that's super common. So I would say if you start working with your mental health professional and you start to do this and you experience an increase in episodes, that does not mean that you're doing something wrong. It does not mean that it's not working. Most likely it actually means that it is working and it is targeting the parts of your brain and body that need to be targeted. At the same time, you'd also want to address like the thoughts. So like for a lot of people, especially newly diagnosed kiddos that I work with, it's like, oh my God, I'm going to die, right? Like I am in danger. This is so scary. Which guess what? That is going to arouse your nervous system even more. You're not going to be able to prevent an episode or get out of one really quickly. So we'd want to kind of come up with phrases that can be calming, specifically about the FND. So for example, okay, my doctor told me that XYZ, I don't have true, epileptic activity in the brain. Like my brain is safe. Or this feels really scary, but they've always ended before, right? So kind of coming up with some of these calm and control thoughts. And yes, I have seen many, many people recover from FND. It's a completely treatable condition with the proper treatment and support. It can sometimes come back. Like we do have like people where it resolved and then a year later something happens and they experience an episode, but then they would just use the same skills and then they would kind of address the FND. So while it can come back, and yes, so cognitive behavioral therapy, I guess like REACT would technically fall under that, but it's not your traditional like challenging your anxious thoughts. So you would want somebody who is specifically trained in FND and not just in like anxiety or trauma, because again, the approach based on like the research, like we just know that treating anxiety alone or treating just the trauma won't necessarily remove your FND symptoms. It might. For some people it does, I will say that, but it often does not. So that's why we want to target the FND episode specifically. And so then JD, going back to kind of what you said, the doctors told you, leave Rachel alone. What was the explanation they kind of provided behind that?
Did they ever give us an explanation?
The few were like,
It's an FMD seizure. It's not going to hurt. She'll survive it. So let her go all the way through it. If it lasts longer than 5 minutes, then yeah, you still should probably call an ambulance. But they were just really nonchalant about it. And for me, I was like, all right, well, maybe I need to get up and do some more research on how this is working. Some grounding techniques is what I call what you see with me doing with Rachel, grounding techniques and things like that. Because I was like, going 3 hours in a seizure is never a good idea for anyone. It has to do some kind of damage to your mind, to your brain.
Not necessarily. I mean,
the damage that I felt was never physical damage, but mental.
Sure. Yeah.
I would be fully conscious the entire time,
Mm-hmm.
just completely trapped. And the way I can explain it is I felt like I was in a completely sealed room inside my mind.
Right, which I mean that even sounds scary, right? And so the good news is that actually that will be helpful if you are aware during the episodes, because let's say you are in the midst of an episode and you're like, well, I can't do bicycle kicks, Julia, like that's not going to happen, which is 100% true. I would start with the most like very basic, kind of like what JD just mentioned, of almost like, yeah, grounding. Like if you can see or if you can hear or if you can feel the ground under you, focusing on that, and then starting, instead of large controlled movements, we would actually do the opposite. We would do small controlled movements. Like, can you wiggle just one of your fingers? And maybe not, right? Maybe not the first time. But the more we kind of try to reconnect the brain and the body, the more times we send that signal and try to do that, the more likely it is that it's going to happen again, that you can get more control from it.
The interesting thing about what you're saying about the large movements is even before meeting you, some of the things, the techniques that I use with Rachel is if I cannot if she's in it longer than usual and I can't get her out of it, and it seems like it's a quite, I don't want to say the B word on here.
It's almost extreme.
It's an extreme one. I've been known to stretch Rachel. Putting her arms up above her head, stretching her out, stretching her legs out. And that seems to do the trick.
It's almost like it reminds my body that, yes, it can move.
Right. And, you know, if that's kind of where we want to start, that's great. Again, you can work with like your trained psychologist who like does react, let's say, for example. Again, the goal is that eventually the person would be able to do it more independently, starting small, because otherwise we wouldn't expect to regain that sense of agency or become more independent with it. Which is the hard part, right? And it's really, and you kind of mentioned like, yes, we have had people who have episodes that last hours, like hours. And especially the first few times, that's the extinction burst I was talking about, right? And that is really hard. It's exhausting. It's physically exhausting.
So what would you say to individuals that actually cannot move their limbs during that time period, even when they come out of it? Because that's what happens to her a lot. She'll come out of it, and now her limbs won't move at all.
Yeah. So I would, if I were working with a family, I would recommend so we would have a family plan, the patient plan, and we'd have like a school or work plan. And so the patient plan is, okay, we would try to do the posing responses. You're going to practice building strength, stamina, all that stuff. But then maybe in this case, the family plan is actually more important, right? Or where we make the most progress at first. So we'd recommend that parents step aside and step away from the person experiencing it, which again seems so cruel, right? It seems so mean, but it's kind of like why parents force their kids to eat broccoli or go to school, right? Even if the kids don't want to. Like, yes, it seems cruel, but the goal is that long term this will be helpful. So we have parents step away, and you can keep your child in your view, but you wouldn't be like in front of them or talking to them. And we would wait for the child, like, okay, they come out of the episode and they would practice trying to regain their movement, their sensation from that sense of paralysis, however long that takes. It might take an hour, right? But that means that for that hour, nobody's really engaging with them. And that allows their brain time to self-soothe, right? And then say, okay, what do I need to do to get that agency back? And that's kind of what we'd recommend. So we'd probably focus more on the parent plan, like the caregiver plan, rather than the one-on-one plan. And we would have the person experience a full episode. We never call EMS actually. They can't do anything, right? They're
with rescue meds often, unfortunately.
there's not, if the seizures are functional or the like non-epileptic episodes, we wouldn't really expect we wouldn't want to rely on the rescue meds because
yeah, it sedates me and it gives me like I actually
It makes
had it
it
happen
worse,
once
yeah.
where I ended up having back-to-back seizures for the next 3 days because of it.
Clusters of them.
yeah, we don't recommend that for our patients. So it's kind of, I think everyone can talk to their healthcare provider, but I specifically collaborate with schools because schools obviously have their own policies of having to call EMS. So we have to do a lot of education, like the amount of times I spend on the phone with the schools is a lot because it's so important for them to understand, like you are going to be accidentally making the child's experience worse because you're making their nervous system freak out, you're making their body freak out, you're also calling a lot of attention to it in front of their peers. So I would expect the child to actually have more episodes at school if that happens.
And they're gonna, like you said with the shrimp, they'll associate going to school with the negativity that happened if they had that episode, and so that'll just they'll ramp up their anxiety. Make
Yeah.
it, yeah.
Yeah, it's really unfortunate. So I spend a lot of time, and I'll be honest, like a lot of schools are really great and really supportive and work with me and just are amazing. And some, are concerned about the legal implications. So we write notes from us and the neurologist saying, do not call EMS. Like we take the responsibility on ourselves. And that kind of is what it is. So, but yes, like the initial part of treatment is really hard and really tough. I don't have any way to sugarcoat that, where I have had patients go through episodes several hours long. They are exhausted after, and it teaches the brain that it can handle it and it will end, right? Eventually, maybe hours later. Other times I hear people talk about how they'll have an episode, get out of one, go back into one, get out of one, go back into one. And that's super common too. And it's kind of trying to do the opposing responses, again, that you would create with your team when you can, and trying to get back to the activity you're doing beforehand. So if I had a teen that had an episode at school, I would actually not want them to go to the nurse's office. I would encourage them to get some water, whatever, walk it off, and then go back to class and go back to doing what you were doing. That helps reset the process in your brain and your body, like we're okay, we're fine, we are safe, we are able to deal with this. So there is not a quick way or a super easy way. And I would honestly argue that maybe it's even harder for parents or for caregivers because it's really hard to see your partner or your child going through this, I would imagine.
I think, honestly, it's probably harder on our children than it is on him. And I know it's hard on him. That's not me discounting you at all. Please understand that. But because they don't have the same knowledge that he does. They don't have the experience with everything I have going on and the doctors, because they don't come to the doctor's appointments and stuff. And so they don't hear all of it and everything. And so they're just seeing something's wrong with mom.
Yeah, but we do hear a lot on our videos is if I'm not around, I'm talking them through it, on the cameras. And a lot of people will point that out. Even when people take our videos and repost them, they'll take out the part where I'm actually talking to the children. But I'm usually talking to the kids through the camera, through a phone, and unless I'm just not home at all and not watching the camera, which is extremely rare because I spend a lot of time around my wife. But as far as with the children, I think one of the most important things, and I'm going to say that on here right now so everyone can hear me, one of the most important things we did for our kids were to get them tested and get them psychological help, therapy, basically. Get them therapy, because if you're going to sit there and every day have an invisible diagnosis, your children are going to see this. And so between you and you need to build a team around them that can support them through this entire thing. So I wanted to make sure I said that on here right now.
Definitely. And of course, it's hard on kids. And like you said, they don't understand as much. So using like child appropriate language, saying that I know, and we kind of sometimes have like teachers share this with the rest of the class if it's becoming a concern. We'll kind of write a brief script of something like, these episodes look really scary. The doctor said, mommy is okay. She's safe. they look really scary, but mom can handle it, and she's always come out of them. Kind of making it child friendly, child appropriate, so they don't worry about it. Of course, they probably still will, but kind of that's how we explain it to other peers in the schools if that's something that our patient wants us to do.
Yeah, I was gonna say it was probably kind of hard for our kids when we just switched schools and what was it? Kids found out about Rachel's story and from our daughter and didn't believe her, and so they didn't treat her that well until the staff, the faculty stepped in and said, no, we should probably let you all know, yes, Isabella's not lying, but we had to speak with her and say, hey, we're going to go ahead and have individuals come and speak with you outside of here. We're going to use the correct language, but we also need the faculty to be supportive as well. So I'm glad that you speak with the actual schools. My hands a lot. I'm glad you speak with the schools and give them a environment, help them, create an environment that's safe. I wanted to make sure I said that.
Definitely. Yeah, it's really important to, like, when I see a comment about siblings, absolutely. So if we have a teenager having episodes, and if we know that, people can develop FND even by observing someone have an episode, it would be important to talk about, like, okay, this is what this is, and your sibling is safe, and you do not need to touch them or helpful. We actually know that the less amount of times we touch a person in an episode, the more likely they're to learn to get out of it independently. And again, should I type in the chat or like react, like retraining and control therapy is what I'm referring to. And again, I use the vague opposing behavior or opposing responses, but it's personalized to every single person and to each of your symptoms. And so, for example, if your kids want to be helpful, which every child wants to be helpful, and it can be really hard to be like, okay, don't touch mom, right? That's going to be really hard for the kids. So you could say something like, okay, if you want to help mom, you can play quietly next to her and just remind her to do her plan, right? So something very simple that gives them that purpose, a way to help you with, can be really powerful for them.
So I will ask you this question, because I know you've seen our videos by now, right?
A couple. I try not to, I didn't want to make too many assumptions, so I didn't go too far down
the rabbit hole. Yes. In our, case, with what happened to Rachel, in order for her to get here, we know it's impressive, and physical and mental type of situation that happened. If you were to see another patient that has gone through something similar as Rachel, how would you approach that? Because I know that you're using the hands-off theory right now. And then also there's the motor skills, helping them with the motor skills until they can do it themselves. So that's a lot of blended theories in order to help them.
I guess
my
feeling on it, which I fully understand what you're talking about, and we've tried that for me.
Yeah.
But it made me so much worse.
Yeah, this is
mentally to where I was to the point where I almost tried to not be here because of it.
No, I was going to say this is over since you first got diagnosed in 2022
is
yeah. But she's had symptoms of
I've had symptoms. I've had almost all the symptoms except for the seizures
until
since
2013.
Okay. Yeah.
And I didn't get diagnosed until I started having the seizures.
And we started off with hands off.
Right.
Your first neurologist was amazing.
She was.
And so we tried, the motor skills, and then
we did the.
We tried having her do them on her own. And so all of these things that you're seeing us do in our videos are, especially in our earlier videos or years in the making. But now we're at the point to try and not let her stay in it so long. Now, of course, it's the magic of editing. So everyone will be like, "Oh, that's happening in a 2 minute period." I'm like, no, this is about a 5 to 14 to 30 minute period, that we either had to chop up and edit so it was smaller or such. But in this case, I know it would behoove us to try it again. So I'm saying that in front of everyone. And
That's
especially more since we're going to have to do it coming up anyway with the wearable
I'm gonna be
device.
hands off for a while.
But
Which I'm
when
very
that
excited
does,
for.
if that doesn't work out, what is the contingency plan?
great question. And I also think you guys are kind of hitting on like trauma-informed care, right? Like how do we not accidentally make things worse?
Yeah.
And I think that's a great point. And that is why it does indeed personalize for every person. For a lot of our families,
I just want to. I know I'm interrupting. I apologize,
She'll
but
forget it though.
I'm honestly, and the reason why Justin asked this, I began starting to feel agitated thinking about it because it was so bad for so long, being locked inside myself that I began to lose myself, and it got to where I would not interact with the kids anymore at all. I wouldn't speak to my husband even when I could, because I was to the point where I'm going to get locked in my head, and so I need to not have any kind of interaction anymore.
You skipped anxiety and went straight to deep depression.
Yeah.
Yeah.
Sorry, I didn't mean to interrupt. I just knew that I was going to lose that. I apologize.
Yeah,
Oh, no.
You may go ahead. I'm sorry.
I think that's very helpful. Oh, what were you going to say?
I said you may go ahead. We're sorry.
Oh, no, I think that's a really great point. And again, like everybody has such a different experience and everybody has a different approach. And for a lot of our families, like let's say where there is that trauma component or history, or maybe where maybe depression is the primary concern, like in that case, right? For example, or where it's impeding the ability to participate in treatment, maybe that would be a time where we would address that first, right? So again, I'm biased. I love like working with FND. And so like that is I'm like, yes, let's do this. And for a lot of our families, we can still make progress. But if a family is like, this is not feasible for us right now, obviously we don't want to force that, right? It needs to be a choice. And I work with kids, which makes it so much more complicated, right? Because we have the caregivers consenting and not the teen. And I'll be honest, like we can still make some progress, especially with the younger kids, we can. But like when we're reaching the teenage age, like I really want them to participate in the treatment creation, the plan. And so if we're kind of at a point where they're like, you know what, sounds great, but we can't. In that case, we would probably recommend doing like anxiety and depression treatment first, or having support in parallel. So often, like, while I typically don't recommend doing more than one therapist at a time, because a lot of us have different like approaches and might give like different recommendations, that might be a time where it could be good to have a trauma-informed, depression therapist, anxiety therapist, whatever, and a dedicated FND provider, whether that's a psychologist or maybe a physical therapist if you're having more like continuous symptoms. I don't know if that kind of addresses the question.
It's adjacent. Yeah, I know I went into a thought process that I think I wanted to say because of the community that's watching right now, and a lot of them are adults, with they're the caregivers for the children. What do you do if an individual in your age range, as far as what you work with, teens, what do you do if they are nonverbal?
In general, or during an episode?
In general, and have FND.
So like a child, let's say with autism or something,
Yes.
or intellectual disability. I work with a couple kids and it's not unusual to actually have some sort of neurodevelopmental concern. We would probably focus more on treatment with the family, depending on severity, right? And what level of support that person needs. So if it's someone like level 1 autism, then we'd probably not change too much of the treatment and, just move forward with it. If it's a kiddo with pretty notable intellectual disability or something like that, we would probably tailor it more so to the parent plan where they can prompt more directly, right? So like for a lot of our teens, we actually don't even have the parents say anything to them when the episode is happening. But if it's a kid that would not remember their plan, we would have the parent prompt them to do each step of the plan. So I personally haven't actually seen a nonverbal kiddo with FND. I've had some like with chronic pain, but we do more of like a family-based approach, I would say.
Awesome. And what about the ones that, yes, probably more familiar, the ones that become nonverbal because of the speech, what was it called? No, when you lost your speech. Yeah, I'm drawing a blank right now. Just the loss of speech during these episodes.
My brain's not functioning.
Yeah, I got you.
I'm sorry.
That's fine. So what about those individuals? Because, I mean, it happens to the adults. I know this from experience, but what do you do?
Okay, I see what you're saying.
Yeah.
So like if like aphasia, or kind of like almost like selective mutism. Oh gosh, my cats are fighting. Or like selective mutism or something like that. We would practice with very small like sounds. So like it's kind of the same approach where it's a rehabilitation. I guess I should have said this in the beginning. This broadly we consider like rehabilitation psychology, right? So these are techniques that we would use for people with brain injury or with spinal cord injury, right? Where we start with very small goals and build up on that. So let's say it's a person who, for whatever reason, after an FND episode, cannot communicate, right? Or is not able to verbalize or talk the way they normally would. We would start with having them practice humming or practice like any sort of non-verbal production with your vocal cords, right? Any noise that they can make. And then maybe exhaling just like one letter, right? So kind of the way we would do like speech and language therapy after a brain injury. Again, I'm not a speech pathologist, but we would use that same approach where we start with very small goals and tailor it for each person.
That's exactly what I went through when I did speech therapy.
We were just talking about the fact that you said if they had brain or spinal, and she has both. And so that's why we were
kind of laughing a little bit, because I know that my causation of however you want to say it is kind of like so multifaceted with everything that happened to me. So it kind of like any diagnosis, like cause of diagnosis you could give has like I could have like a touch of somehow. Does that make sense?
And that's how honestly often that's how it is. Like we're not simple creatures, right? We humans are complex. Our brains are messy, and honestly, who even knows how our brains work, right? Like it's very often we have kids who, again, like people who come in with multimodal or multifactorial presentations, and so you would. Mm-hmm.
I was going to say I found it interesting, and I'm going all the way back to the beginning of the conversation of when you were talking about making a plan for before or after an episode or a seizure like episode, and it's interesting because of the fact that I don't know if we're teamed up with Neural AI monitoring. Mm-hmm. That's exactly what they're working towards now. They have the device that's going to be coming out that Rachel's going to be testing. That should be eventually, the goal is to have it let the wearer know, or the family members know, that the wearer is going to be going into a seizure or a seizure-like activity in a moment, and give that opportunity for the individual to prepare for that. Mm-hmm. Unlike the watch that Rachel wears now, that only performs 3 seconds after
I've fallen.
Yeah, she's fallen.
Helpful.
Isn't it now?
Yeah, that'd be really cool. And I think I'm excited to hear kind of more about it. I know they've been using machine learning to identify or like properly like sort people who have FND versus not. So there's definitely some cool new research coming out. And I think there were a couple questions earlier of like, what are the functional imaging differences? I think, and there's a couple, I like printed out my favorite articles because I don't know all the medical terms, but we know that there are, from functional imaging in groups of people who have diagnosed FND, there are differences in the areas of the brain that are in charge of attention, self-agency, prediction, or inference, which is kind of what we talked about, right? Like your brain predicting the wrong, or like mispredicting something, as well as emotion and threat processing. So there are a lot of like differences in the functional imaging studies. And so kind of like with OCD, like there's certain parts of like the brain that are more active in people with OCD versus people without OCD, right? So it can be kind of similar where like it's one of those predisposing factors. Doesn't mean you're going to develop FND.
So can I ask you a question on that with the brain imaging? So I actually have 2 spinal stimulators because my brain tells my body that it's in pain when there's no pain being caused.
Mm-hmm.
And so will the imaging show up when I'm going through the pain spike that sends me into these silent storms, invisible storms, sorry, or because my brain is already doing this actively nonstop, will it not show up as well?
I honestly, I'm not sure. I'm not sure.
I have no clue on that, like honestly, because you talking about it made me think, like, will the infrared even show anything different?
Well, I don't even know if she knows that the device will be using infrared technology.
I've heard of it because I work with chronic pain a little bit. Obviously, it's less common in kids to have that device, but I'm not sure. That'd be an interesting question for a neurologist or like a imaging doctor, because that'd be pretty interesting.
Yeah, I'm really curious because now that you're talking about it, I'm like, well, is it even going to show any difference? Because I know already, like I've been through pain management. I've been through like I said, I have 2 spinal stimulators. One's attached to the top, one's attached to the bottom. And so I have them, I can't use them anymore because they now send me into the invisible storms, but gotta love it. But before this, they would work to where it would keep me in a tingle, numb feeling versus constant horrific pain. And so I'm wondering if that's even going to be able to show up now when certain things happen, because if my brain's always signaling incorrectly, so.
I mean, it would probably show something of like certain areas would probably be more active, whether that's the areas that are, interpreting the danger or the threat part, or, this is just me making an educated guess. This is not like evidence-based. If they're not actively
there's not a lot of evidence base out there yet for imaging. There's not a lot. Yeah. It's still being researched to where, for FND, it's still being researched to where it's finally being published, correct?
Mm-hmm. It's definitely newer, yeah. Because there used to be like a thought that there is no differences, right? And now there is some evidence, there's some newer evidence where there are the functional differences. I think there's I don't think it's a published study, but I saw somebody writing something about like structural differences. Again, that one I think not necessarily. Yeah, that one I just saw a brief mention of, and I don't know how accurate it is. But the functional imaging, there is some evidence. Again, it's not like we would do it on you, Rachel, and be like, oh, well, this is how we know you have FND. It's more like if we have 2,000 people with and without FND, and then we compare brain regions in general, they did find statistically significant findings, basically.
Did you read the question from Christy Quasi? And the reason why I asked is because, yes, the TENS unit is what we're actually talking about right now with brain. Kind of. But it's it's a spinal stimulator, it's an internal TENS unit.
That's the way that my pain management described it to us was, imagine having a TENS unit that's on the inside of you. Mm-hmm. And so, and again, one thing that I'm going to say for you, to Christy, is talk to your medical team.
Yeah.
Because what works for me may not work for you. And we will not give you any we're not going to give you any kind of advice because we are not your medical team.
We can tell you from lived experience what we have learned and what we have gone through, and that's why we're bringing professionals onto the channel so they can also tell you.
And
what
she
they're
is mainly talking about the documents and the not the documents. I'm sorry,
the
studies and everything that she's gone through and researched, and for her own for the practices she's doing with the kids. Correct?
Yeah, and yeah, some of the research is like for adults, but like I said, I'm more versed in kids, but absolutely. And kind of going back to the question, Christy, though, it goes back to the overall view of like the goal is to use treatment, like React, for example, to be able to get out of an episode or even prevent an episode or not even have ever episodes without any sort of additional spray bottles, right, or things like that. And kind of going back to like, I'd rather somebody do that and like then also use our skills than, not do anything at all. Right. So I think it is going to be finding that balance that works for each family. And again, that's why it's so good to personalize. Like I don't have, I use the foundation and the knowledge base similarly to everyone across all my patients, but every patient has a different plan and we write out a specific plan and we write out a specific plan for parents and a specific plan for school. So I tailor it for every single one.
Chrissy, no, what did you call it? Twazi?
Yeah, Quasi.
You keep mentioning the same book. I've seen you write that some.
Okay, so
Are you talking about the DSM-5?
No, she's not. So what happened is her 21-year-old is who her child is, but her child's doctors and teams have said you need to work with this book and work with a psychologist, and that's the only help that they've given her.
What book is it? Do we know?
It's not like she's written the book
Chris,
in.
can you put it in the chat with what book you're talking about? Because I'm seeing it go by, and I don't know what the book is.
And the ones who are saying that they don't feel like their doctors are working well for them.
We say it all the time.
There's a couple things. Like if you look at Miss Tate, she completely reset her team.
Yes.
She now drives 3 hours to get to a specialist.
Yes.
But she reset her team because she was not getting the proper care
Didn't
for
Miss
her.
Tate buy the book?
So,
Yeah.
but so the one thing that I suggest very, very, very often is if you are unhappy with the care you are receiving, ask for a different doctor.
Mm-hmm.
If the medical team will not provide one for you, there is something called patient advocacy.
Yep.
Every hospital and medical office is supposed to have one, and they're there for the patient. So, and it's not I'm angry at the doctor because they didn't give me what I want. That's not what we're talking about.
No.
We're talking about when it's repetitive neglect
Misuse.
or
Mishandling of your care.
of your care.
I was gonna say mishandling
Like
of your care.
I had a doctor who he knew how to help bring me out of the episodes, and the team, everyone knew everything about my care and the things that I requested. And instead, they stood around me while I was hooked up to an EEG and talked bad about my husband, talked bad about me, and then finally were like, "Well, I guess she's not faking, so we should probably call the ambulance." Like,
Yeah.
That's horrible.
So, what was that one?
That's horrible. Yeah,
It was awful.
Well,
and
we-
like literally,
we get
I
used to it
came
at
out
this
of my
point.
seizure
Yeah.
with tears just streaming
Yeah.
down my face. Like I was not crying while I was in the seizure, but I came out of the seizure and immediately I was already crying. It was awful. When things like that happen, you do not have to stay in the care of someone who does not care
No, we will say
about your
this.
health.
First of all, look in the chat. Dr. Julia just put check out retaining and controlled therapy, FND React, by Dr. Erin Fabian, right? Fabian?
Dr. Erin Fobian. Yeah, and so yes, that's kind of the treatment that I was talking about, and they have some great resources and some great publications. There's also something called FNSD Special Interest Group, which is technically for psychologists, but they have parent and patient resources there with like not always the most up-to-date providers who provide FND services, but your doctor should be trained in something for FND. So we have, I do feel like I'm a little bit biased, but I would say like our hospital has such phenomenal neurologists who spend hours with families, like literal hours with families. And while we have a dedicated FND clinic, but also even just like on the inpatient floor, all of our doctors are trained in providing an explanation on FND, making sure it's clear that, nope, it's not just, not you faking it, right? In short. And they do a really great job of explaining it, and they collaborate, and we have specifically trained physical therapists. So I would even go specifically to a designated physical therapist. So, and not any psychologist can treat this, right? Like there are people who've been trained in this, like I did my fellowship in this, my clinical internship, or like like our residency and my practicum training, right? And I'm trained in other things, but this is just like a very special interest of mine, plus like chronic pain. So not everyone in our department even does this. There's about 4 of us that treat this comfortably. So telehealth, even if you know, they'll probably want to see you in person, and like maybe the first like multi-D clinic visit is in person, but then after that we can do telehealth, right, for a lot of people. Also, the website I sent, like the React website, I believe they take some adults, and the providers are licensed in PSI-PACT states. So there are several states. Oh God, sorry, my cat decided it is time to make an appearance. It's been patient.
We have it too. I'm surprised one of them hasn't jumped behind us. So
I know the other girl is hiding, but the boy is here.
ours are opposite. Our girl is always wanting to be on camera, and the boy is always hiding. So
that's fun. Our boy is younger. He's like 8 months, so he's still tiny. Well, he's huge, but he's mentally tiny.
I was gonna say we have his and her dogs, and we have his and her cats.
Oh, I love that.
So I'll have a couple things I want to say really quick since you kind of paused. Number 1 is everyone go follow Dr. Julia.
Yes, go follow her.
Okay. Number 2, everybody follow Ann Wick. We can't pin her, but she's in the chat. So go find her and follow her. She's actually a resident therapist.
Yep, there it is.
And it's ice.
Yeah.
That's the ice. Okay, sorry. I was wondering if it was one of our animals. My bad. So everybody go and follow those 2 people, but then there's one more follow that we would like for everyone to go do. Type in Neuro AI monitoring, and everybody go follow him as well. That's the company.
On TikTok.
On TikTok. That's the company that is going to be providing the wearable so that we can start that study.
I was going to check the mail today to see if it was in. He was supposed to mail it off on Tuesday, but today is his son's birthday, so I wanted to say happy birthday to his son.
Which one?
I don't know which one. He just said I'm out to dinner. I just texted him actually.
Gotcha.
The CEO of Neuro AI Monitor, and he was like he's going to look in on the live while you're speaking, but I wanted to make sure I give a shout out to his son. Happy birthday. And to his son that runs track, I'm still faster. To his son that he makes grilled cheese, I make it better.
No.
And so, yeah.
Okay, so there's a question here that I wanted to go ahead and ask you, and this is actually from the resident therapist. What is the overlap symptomatically between FND and disassociation?
I mean, there are some FND episodes that look basically just like that. Like, for example, some of our FND patients report just like what looks almost like an absence seizure, right? So kind of like that zoned out, you're not responding, but it's brief. That can look similar. There can be one where it feels like out of body, where maybe you can hear and see, but it feels out of body. But I think, it depends, is the disassociation, is that part of your FND or is it part of a different diagnosis, right? I would say the treatment is probably going to be pretty similar. At least for FND, I can say that what we recommend is as soon as you notice that happening, kind of redirecting yourself back to the present moment, whether that's through mindfulness or grounding activities, whatever happens to work best for you. Okay, and then so you're describing like also movement. So yeah, so I would say in the experiences we've had where patients kind of report that let's say you disassociate and maybe it's like an out of body experience, you can't really move, you would do the things that you could do. So like, can you move your eyes or can you focus in on what you hear? So kind of that very much like 5 senses, grounding, bringing yourself back into the moment. And then can you wiggle a toe? Can you try to wiggle a finger? And if not, once the 10 minutes are over, going back to whatever activity you were doing. Basically, we want to get back as quickly as possible to whatever activity we were doing before the episode happened. That helps tell the body we're safe, you're not in danger, you can get out of the fight or flight mode. Hopefully that answers your question, Anne.
I know it's so interesting to me because like everything that you are saying that, to use, I'm sitting here and I'm going through in my head, okay, so did I actually do that? Yeah, okay.
Yeah,
every single thing that you've spoken about, I literally am sitting here in my head trying to be like, did I actually do hey, yeah, no. And I'm like actually thinking of certain like episodes when I've gone through, like I've been laying in the bed and I will come to where literally everything is just turned off except for my brain. I can't move my arms, I can't move my legs, I can't move my torso. And I will sit there and I'll be like, okay, well, I know I'm okay and I know I'm gonna be okay. I can't open my eyes, but they're not like fully closed. I'm all right. My eyes aren't going to dry out because they're closed enough. And I'll go through the process of everything. I'm like, okay, well, I'm already in bed. I know I'm safe. I'm going to just try and go to sleep. But my brain won't stop.
Mm-hmm.
And at that point, it's like I'll be in that where, honestly, if someone doesn't come and check on me, I can be in that for very long time,
for the whole night.
And then the next morning I wait. They'll come to wake me up, and I'll only have gotten like maybe 30 minutes of true sleep.
Mm-hmm.
Fortunately for her, I don't sleep.
Yeah, so he often wakes me up, but well, I say wake up, but that's not what I really mean. He'll bring me out of it.
Yeah, because I'll walk around to her side of the bed and check on her every night, and I do it quite often and throughout the night and during the day.
So I won't lie, like I'm listening to everything you're saying and it brings me so much hope for the community, but almost hopeless for myself. And I don't mean that in a negative way at all to you. It's just one of the things of I've literally been, everything that you have said and suggested are things that I've done for years, trying to ground myself, trying to get my body to move. Like I would be, when it first started and the doctors flat out told me, well, the neurologist who literally didn't even want to look into what FND was, when he was like, well, you have to just leave her alone. Don't do anything. She has to be able to come out of it on her own.
Right.
I would be laying there completely, to me it felt catatonic almost, like I'm literally, my brain is still functioning, but the rest of my body is just complete brick. I'm like, okay, Rachel, you can move. You can get up. You can move your legs. You can move your arms. You can speak. You know how to do these things. You can do it. It's possible. You were just talking a second ago. You can still do this. And I'm going through and, hi, Kitty. I'll be going through and I'll be like, okay, so I know I'm in the bed, or I know I'm on the couch. I know that I am safe. And like, everything that you've spoken about, I do, but
I also want you to, again, not your provider. These things take time. So I think oftentimes people will, and not just for FND, will say something like, well, that didn't work, right? And it could just be it didn't work fast enough, right? Sometimes our expectations, like, this is not going to work. Like, you're not going to do it today and then it'll be cured forever, especially if you've had this since 2013, right? That's 12 years of patterns that your body has learned and signals your body has been sending. So there are a couple, like the things that we would tweak for every different person would be things like JD, like not checking in on you, right? Kind of, and that goes back to our conversation earlier where it's like, oh my gosh, sorry, Percy is very much in it, where we would, maybe this is not the right approach and we think you guys wouldn't be able to do it yet because it would lead to significant mental distress, right? And our goal is not to do more harm. So these things, like this approach seems to work better for a lot of people than like traditional CBT talk therapy because we're doing the bottom up approach, but it does mean that you are left to your own devices for hours and hours. Maybe there'll be several sleepless nights. We would, again, expect it to get worse before it gets better, but I wouldn't want you to kind of just start doing all this without the proper support, right? So like finding either like a React provider or another provider who maybe has an approach that you find better for you. Because like a lot of my patients, like maybe I'm not the best fit and that's okay too. And then internal family systems, I think, is a great treatment. Again, that's more of a talk therapy. I would recommend anything that has, like, if there are certain things that seem to be triggering it that can be resolved with IFS, I think that'd be great. I wouldn't expect that to treat the FND per se. So we would want to focus more like on the physical rehabilitation or cognitive rehabilitation aspect, in addition to any other therapies you would do.
Okay, so I apologize. We actually one of our mods is having a technical difficulty, and so I was talking to Justin, so I missed a little bit of what you were saying, and I would really like to be able to hear it. So could you say it again for me? I'm sorry.
Oh, the internal family systems part, or which part?
All of it. I'm sorry. I missed what you were saying after we spoke. My brain went into work mode because we were having a technical issue.
Okay, yeah. No worries. I think, a treatment it has to be personalized, and it has to be something that you are comfortable with, right? Like, if these are not things that would be comfortable for you and JD to do, again, I'm using you as an example because that's who I'm talking to, right? That we might, maybe this treatment approach would not be the right fit at this time. It doesn't necessarily mean that it wouldn't ever work for you. It just means like maybe now's not the you can't do this right now. So for example, we would actually have like JD and kids not touch you ever during an episode, regardless of how long it lasts. Maybe it's 3 hours, maybe it's 5 hours, right? But if that would cause significant distress that you're not able to deal with right now, we wouldn't want to do that without your consent, right? We don't want to cause harm. That is never our goal. And so, the goal is that, and this is not going to improve quickly, right? Like, I don't know how much of that part you heard before. Like 12 years is a long time for your body to have certain pathways in your brain. So it would probably take
for so long.
Yeah. So it would take a while to kind of retrain the body, and it can only do that when it's given the opportunity to do so. So days and days of practicing, weeks of practicing. And what I've noticed in a lot of our patients, yes, for some it's like a switch flips and they never have another episode again. But for a lot of times it's okay, we were able to delay an episode starting. The next week we were able to prevent one episode, but we still had 3 that same day. Or that day I delayed a lot of them, and then I came out of one more quickly by using my opposing responses. So there's a way to have success in a variety of ways, and treatment gains without it fully going away immediately. So that can give you kind of some more hope. And again, maybe working with a targeted adult provider, they might be able to give you kind of more useful tips and tricks.
Yeah, definitely.
Yeah, and I see the IFS question.
There was a couple by Anne.
Yeah.
Would you ever use internal family systems for treatment?
And so, I chatted about that earlier, but basically it can't, if there's a comorbid condition that can be treated with that, or a symptom that can be treated with that, I think that's a great therapy approach. Wouldn't necessarily expect it to fully treat the FND, because we want to use something like the physical and cognitive rehabilitation, right? So physical therapy, or a rehabilitation psychologist who can kind of help get back that motor and cognitive functioning. But I see you're talking about chronic pain. I could see that being helpful. With chronic pain, I was trained again more in a rehabilitation psychology. It's a little bit different, but we can definitely a lot of us, I guess I would say, combine a lot of different modalities together and kind of make a hodgepodge that works for each patient. I'm just trying to see if there's any other questions.
What is it, Feisty? It said he is at Stanford and is supposed to be the expert for the state.
I think that's talking about the doctor that works with her son.
Okay.
Yeah, I think it's also about fit, right? When we talk about psychologists, often or therapists, the majority of treatment progress can be attributed to the relationship with your therapist, right? I would argue the same thing can be true for your neurology provider. If you don't trust that they have your best interests at heart, why would you follow their recommendations, right?
100% agree with you. 100% agree with you, yes.
So I think it is really important to make sure you're going to be with a provider that you trust. And so I love to collaborate with our neurologists, at the hospital I work at, and it helps us establish really strong relationships so that we can feel comfortable referring patients to each other, right? I don't want to send a patient of mine that I care about to a provider that I don't trust, right?
Yeah, it would be a setback for the treatment that you all are giving them.
Absolutely. And sometimes if they come diagnosed from a different clinic, a lot of our first session is just redoing the education and explaining it's not trauma caused necessarily, because they might not have trauma. It might not just be anxiety. So for the neurologist, I would try to find a neurologist within a hospital setting, like an academic medical setting, who has trained in one, because they tend to have more like liability, like they have to practice based on the literature. So I would find somebody who specializes in movement disorders, or because a lot of like general neurologists will see you briefly, but then not be able to follow you for the FND.
I think I was lucky with my first neurologist.
Mhm.
You know?
And yes, conversion disorder is the old diagnostic term for FND. Other words you might hear are PNES, so psychogenic non-epileptic seizures. You might also hear FNSD, so functional neurological symptom disorder. But
That's a new insurance term now.
Yeah, I don't. It's yeah, I don't have the new DSM, but the old one it's like conversion disorder and then parentheses functional neurological symptom disorder. I would say in the like community we don't really use FNSD anymore. I'm not sure why, but we kind of use FND now more consistently.
That's funny because my most recent neurologist is the opposite way around. Their insurance system now uses the FNSD.
But some can be behind the others.
So that's really interesting.
Yeah, it's
because they don't have anybody who's focused on FND,
Yeah.
so that's another thing. So they could be behind the curve because they're not really focusing on that versus other neurological disorders. So
yeah, and I'm seeing a lot of comments about like diagnosis. So when it comes to FND, we know now that there are very specific things that tell us it's FND and not epileptic. So usually a well-trained neurologist doesn't even have to do an EEG. Like their predictions are pretty much always like very highly correlated with like EEG results. Because sometimes you might not have an episode while you're recording an EEG, but it could still be a true epileptic seizure, or it could be a non-epileptic seizure, right? And so it's based on, like epilepsy is a clinical diagnosis, which means it's based on presentation. Right. So even if they don't capture electric activity, it doesn't mean you don't have epilepsy, right? And so a good, well-trained neurologist should be able to identify and explain the positive signs of FND. It's not a rule-out diagnosis, right? It's not just like, oh gosh, we didn't have anything else to diagnose you with. This is what you get. It's no, these episodes look like this, and this is how we know. There are very like consistent positive symptoms. And so there's one that said a regular doctor told me I'm non-epileptic. Yeah, so a lot of like some emergency doctors can be pretty well trained. There is a slightly higher misdiagnosis rate in the emergency department. But if you're seen by like a neurologist or somebody who does a lot of epilepsy work, they're probably more accurate. And I would ask them to explain like the positive symptoms. If it's just, oh, we didn't find anything else, that's not good enough, right? We need them to explain, how do you know? Tell me the positive symptoms of FND. FND can go away. Yeah, sometimes it actually resolves on its own. Sometimes it doesn't, but it is treatable.
Yeah, thank you, and I'm glad you're reading the comments because I have to keep going like this just to read them because I'm trying to
just those that are popping up.
Listen intently, but I'm sitting here going like this, and then our dog that has cancer is walking around the house and is being sassy because you're deciding not to have cancer. You have to come and sit right here.
She came down the hallway, and like it was one of the things where she like stopped and she's like, "Oh, you're here? My bad. Let me do this really wide circle and walk the other way."
But she didn't walk the other way. She sat down and looked at us.
So yeah,
and kind of put her nose in the air like, "You all see me here. I need attention."
Like, don't be suspicious.
Yeah, that's why you saw both of us lean to the right. We were like, "Where's she going?"
Oh my God.
Can't trust her. She's like 13 years old with cancer. So we can't trust her.
Can't trust her anywhere in the house, honestly. Baby Cup, I think it's awesome that you're going to be going to the KU Medical Center. That is really awesome, and I'm glad that you're going to be going somewhere where hopefully you'll be able to get more assistance with your diagnosis. That is really awesome. And Christy Quasi, of course, is saying to you, thank you for the helpful suggestions. And I'm going to say, and I know we're not like fully done, but I want to say right now, I really appreciate that you were willing to come and speak with us. I know that we are literally just two random people that have no actual, like, well, I have no medical backing at all. Justin's is, it's not medical clinical. But we're not medical professionals in this aspect. But the fact that you were willing to come and speak with us and talk with our community and just give the information that you have, we really appreciate it. Well, I appreciate it. I don't know if you appreciate it or not.
And thanks so much for reaching out. I think, one of my goals is like community outreach and just like community work, because nobody has access to like scientific literature, right? Like it's behind paywalls. It's, and also even people who work in the medical field, like we all have our little subspecialties. And this just happens to be like my favorite topic I can talk about for an hour and a half without taking a breath, right? And so I'm glad that this was hopefully helpful. Rachel, I am sorry to hear maybe it made you feel a little bit more hopeless.
No,
but
it's not that. It's really not. And I know that.
Well, first of all, we know you work with adolescents. So we make sure we prepared the community coming into this that, yes, what you're hearing today will definitely be focused generally on teens, but she knows what she's talking about adults as well, but she's focusing on teens.
Mm-hmm.
Said that, like you say, like I say all the time, like Ann says, every patient is an individual.
Yeah.
So you have a specific case based on their medical history.
Absolutely.
You have to take that. We have to factor that in. No matter what, Rachel's case is probably one of the more drastic cases of how you can develop FND, and I say this constantly, which is why I am glad that we're starting to bring on professionals so they can also give their opinion on how this whole system is working for individuals versus putting everyone in a box.
Yeah, absolutely. I mean, everybody's presentation is so different, and again, we want to make sure it's tailored and targeted based on, right, the evidence. Like we don't want to like reinvent the wheel every time, but at the same time, it is so important to make sure every patient that we see, like we have dedicated time for them. I'm just I know how common it is to have such negative experiences with the medical community. I'm hoping that, now there's a bit more information and education. I've noticed a big shift in even like our hospital and I think it's because of the amazing people I work with specifically. Maybe it's not the entire hospital, I don't know. But there is, I think, slowly a shift, and I think continuing to talk about it, continuing to spread some awareness is all that we can do. And
I personally want to say thank you, because I've had more doctors that have had negative effects in my healthcare than positive.
Yeah.
And so the fact that you are willing to understand that the individuals with diagnoses are not going to fit the same plan. The same treatment is not going to work for, and like you can have two people who have very similar presentations and treatment may not work the same for them. Mm-hmm. And it has taken like bedside manner, treatment plans, no matter how you look at it, the care that I personally have received has not been great. And so I know that I tend to be a little bit more obstinate when it comes to medical professionals.
Yeah.
Because I'm preparing myself to be misdiagnosed.
Be disappointed.
To be disappointed, yes.
Right. So, and I think that's fair, right? Like, again, you're basing it off previous experiences. And I think a lot of that for providers can come from like fear of the unknown, right? Like if people don't feel trained or don't feel educated in it, they're going to push against it, right? Like, oh, this is not something I can do, like, but it's hard to admit that and it's hard to accept that. So we're going to blame it on you, right? Oh, you're the patient, you're the problem.
I think the best for me is the fact that I've had so many providers who have been like, well, we don't really have an answer for you, so let's use you as a study. And I'll have all my students come in and be like, hey, so look at this patient and you need to diagnose her now. And the doctors had to have us tell them what the problem actually was. Like, I had an optometrist who walked in and say, what do you mean you can't see out of your eye? Your eye looks like it's working just fine. Well, the optic nerve is no longer working. So if the optic nerve doesn't work, the eye doesn't see. So even though the eyeball itself looks healthy, and so I've had many doctors who they would use me as a teaching tool because they didn't have the answers to give.
Right.
So
Now, once again, I want to reiterate that. Thank you for joining us tonight. Once again, this is Dr. Julia.
yes, we
She's a
really
psychologist.
appreciate that you were willing to come on. Yeah,
Yes, and she specializes. Well, not specialized. She works primarily with teens,
I love
and
you.
now, as she said, in the school systems as well. So
I like volunteer with school systems. I'll like sometimes do like talks and stuff.
That's amazing.
So
I
if you
find it
live in
fun.
the Texas area,
Mhm.
you may look her, find her on TikTok, and follow her.
Well, everyone,
Instagram. Yep, I post a lot of silly videos, some educational, some silly, and I do.
Stop with that.
And I just want it to be more accessible because, like you guys have clearly experienced, it is hard to get answers. It is hard to get the proper diagnosis and things like that. So I hope this was helpful. I'm happy to kind of chat more and check back in the future.
Yeah, I was going to ask you. I didn't want to impose, but I was going to say, would you like to come back on again?
Of course, I think it'll be fun to have more discussions, and if there's more of the community that would find it helpful, I am more than happy to. Or if people are like, no, we're sick of her, that's fine too.
Well,
I promise that no one is sick of you
yeah.
because the comments, I don't know if you've noticed, but the questions and comments haven't stopped since you popped in here.
Oh,
So it seriously is, and I warned you yesterday that you would not run out of things to talk about
Oh,
because
trust,
of this
yeah.
community.
Yeah.
So,
that's true. I was like, gosh, I don't have enough to say for an hour, and you're like, don't worry about that.
If you notice, there wasn't any trolls. It's a very welcoming community.
well, there was one we just got.
Yeah, but they bounced them really quick.
Yeah, that's
so
the reason why we have
like
moderators,
literally
yeah.
the type of platform where you can literally come on and have a full discussion and really get out all the things that you want to say.
I want to make
especially
sure
your
that
presentation,
Dr.
but-
Julia sees this, so here's
Yeah.
this really quick.
Go
Mrs. Tate says, these talks help us know what questions we need to be asking and to whom. It helps give us direction. And so, if nothing else, Dr. Julia, thank you for helping give direction and the questions that need to be asked for this community. For the parents who have children who are going through FND or similar diagnoses. Thank you for taking your time and giving us a little bit more direction and understanding on what it can be going on.
And I was going to say, maybe next time we'll have you on Facebook instead, because everyone on Facebook keeps yelling at us
Oh,
for being
yes.
live on Facebook. So,
Yeah, for sure. No, I'm happy to chat, whatever. Thanks y'all so much. I put another website that I find pretty helpful for patients and families and providers. But yeah, follow along, send questions, and thanks so much for your time, everyone.
Thank you
Thank
so
you.
much, Dr.
We'll see
Julia.
you later.
We really
Thank you for joining
appreciate
us.
it.
Everybody
Have a
say
wonderful
bye.
night.
Have a good night. Bye.
you okay?
Yeah.
All right.
I wanted to make sure that she was able to disconnect well. All right, so guys, what do you think? What do you think about what she was talking about? Do you guys have any thoughts, concerns, questions? Like, now that she's gone, do you have even more questions? Hi, Anne. How are you doing? I'm so glad that you were able to come in and listen. Pickle said that was great. So, but what did you guys think? Like, do you feel like this was helpful? Of course, we talked about you. We talked about you, and we told everyone that they need to follow Anne Wick because we want her to be able to come on.